So next couple of minutes, I'll be sharing the center involving diabetic macular edema algorithms for treatment. So there are some guiding principles in treating center involving diabetic macular edema. The first thing is you tend to classify whether it is center involving or non-center involving. Usually you use the help of a OCT to do that. Glycemic control, control of blood pressure, serum lipids, anemia, they are definitely very crucial whenever you are managing center involving DME. Anti-VEGFs are the first line treatment for CI-DME cases. We switch anti-VEGF or switch to laser or switch to steroid if it is a partial or a non-responder. OCT and vision are the key tests for determining the initial treatment choice as well as the follow-up. You want to do these things. And in case there is a vitreomacular traction and in select cases of a non-responding DME, vitrectomy does have a role. So let's see how this algorithm we do. So if first thing you classify whether it is non-center or center. Non-center things are pretty clear, observe or do laser. And if it is center involving, if it's good vision, you tend to observe. That's what the newer protocol, the protocol V has taught us, that observation does fairly equally good as compared to anti-VEGF. And if vision is low, you start with anti-VEGF injections. And after a couple of injections, you start looking at whether it is a good responder, it is an intermediate response or a poor response. That response is based on OCT and based on the vision. And if you see less improvement and it is a good responder, you continue with anti-VEGF. If it is not a very good one, there is a partial response, you still continue. You know that you will need a couple of more injections. But if it is a very poor responder or non-responder, after 2 to 3 injections, you tend to switch. And switching, you have a choice to switch to a different anti-VEGF or you have a choice to switch to a steroid. Now, many times, though this algorithm is the one which we follow, all of us, but sometimes related to the patient factors, the treatment decision may change. Like if a patient has got a history of a cerebrovascular accident event within last 3 months, you tend to avoid anti-VEGF. You consider steroids. You can still consider laser if there is a single, if you see those cercinates, you know there are focal leaks, you can still consider laser in these cases. If it's a pregnancy, if it is a milder diabetic macular edema early in the pregnancy, you can watch. However, if it is increasing, vision is deteriorating, or if it's severe, you can still consider laser. Steroid is questionable, but though people have demonstrated early pregnancy, even intravitreal steroid causing teratogenicity like the oral steroids, but still it is relatively safe, but definitely no anti-VEGF. Late in the pregnancy, if they come, prefer to wait because macular edema tend to improve after delivery. But anytime during pregnancy, if there is PDR, it needs laser. If a patient is of a poor compliance, you know after 1 or 2 injections, he is not coming regularly. That's again something you can think of considering laser or steroids. If a patient is having a chronic kidney disease and you have started the treatment with anti-VEGF, and on treatment you see that his eGFR, estimated GFR is worsening, you can consider skipping the injection to the next visit, or you can think of switching to a steroid because more recently there are evidences that it affects, especially when there is the renal parameters are deteriorating, not a good idea to continue anti-VEGF. There are several eye-related factors also which affect your algorithm. So if it's a vitrectomized eye with a DME, we have shown now very recently that in the early post, no need to be very aggressive treating these eyes. Majority of them, even without giving any anti-VEGF or steroid, in first 5-6 months, the edema goes away. So this was actually a multicentric study which we had done comparing comparing the anti-VEGF steroid and observation. And we found that post-vitrectomy diabetic macular edema the visual outcome in observation is not as bad as anti-VEGF or steroid. However, if it is a late DME, definitely steroids are having a little more edge because they remain for a little longer time. Anti-VEGF also works pretty well, but you need more injections, more frequency of injections are needed. DME with PDR, we had discussed anti-VEGF along with PRP or a deferred PRP, both options are there. And if it's a pseudophakic eye with DME, it's important to differentiate whether you're dealing with a pseudophakic macular edema or it's a diabetic macular edema or it's a combined type, both components are there. And you can consider steroids if it has reached a plateau and there is persistent intraretinal fluid. Though again in these cases it's not like anti-VEGF cannot be given, but we do know with all the studies that steroid acts equally well as anti-VEGFs. There are some disease-related factors too. So if you see some plaque of hard exudate, these are the cases you want to control dyslipidemia. You want to, again, steroids have shown a little better effect, and lipid-lowering drugs have got an adjuvant role. So you can start on them. Definitely it works well. We also know with clinical trials that people with poor vision and a thicker retina, probably intravitreal ranibizumab and intravitreal aflibercept are better as compared to bevacizumab. The ones with vitreoretinal surface abnormalities, we know that they show a poor response. They have more recalcitrant DME. They don't respond very well to anti-VEGF. You have to tell from starting this patient will need more injections. We can also consider giving steroids. However, if there is a frank vitreomacular traction, these are the cases vitrectomy definitely is important. And not only these factors, but the algorithm also changes sometimes when you assess the treatment response. And if you see a poor response, poor systemic control, you want to have an appropriate referral. If you tend to identify the best response on history or document, and when there is a poor response, you try to use the same drug again. If it's a chronic diabetic macular edema more than 6 months, again, there is some thought that you can think of using steroids. And if you have history of some of the drugs which cause macular edema, more important like thiazolidine diones, niacin, prostaglandin analogs, fingolimod, again it has come back because of renal cell carcinoma, people using it. You need to stop these drugs, have a follow-up, and then decide on treatment. So if a patient is on this anti-VEGF pathway, you tend to review after 3 to 6 months and see that whether you had inadequate frequency of visits or injections and you see a suboptimal response, or even with inadequate visits, you have a good response. So if there is suboptimal response, you counsel the patient, educate him that can he attend more frequent visits or he cannot. If he can, you continue anti-VEGFs. If he cannot, you switch to steroids. And if he is getting adequate response, or if he had adequate frequency of injections and you see a good response, you still continue anti-VEGF and monitor. And if there is suboptimal response, you can switch to steroid or switch to any other anti-VEGFs. So the success of treatment in CI-DME is not only giving injections, but more important is good control of systemic factors, good compliance to follow-up, and good compliance to treatment. And this you can understand very well if you understand the patient's journey. The patient journey is a very tedious journey. He has the initial phases where it's the diagnosis and he thinks that it is the bad luck, he got diabetic macular edema. Then there is this first injection fear. Then there is this, the machine, the assembly line of machines where he's continuously getting injections. And finally, there is a burnout both for caregiver and for the patient. And at some stage, if the things get controlled, his systemic control is good, the eye is responding well, the vision improves, the quality of life improves, and if not, the things deteriorate. The good thing about diabetic macular edema is it never causes legal blindness. Legal blindness is blindness is less than 3/60, hardly you get it with diabetic macular edema. PDR can cause this. Thank you very much.
Do we have any question from the house before we ask the panelist? Yes, you had some question.
Hello.
Yeah.
It's not the question, but my experience about the anti-VEGFs in PDR cases as well as DME. To start with, I will always suggest to give the injection and then go for the PRP. That works very well because of the onset of the action of any treatment modality. The anti-VEGF works within 48 hours, so we know that. We always tell that it's 100 times potent and faster than the lasers. Lasers start working after 2 months or after 12 weeks. We have noted several patients, by the time the patient comes for third PRP, there is a bleed. Then how to answer it? We convince ourselves and patient that we have done at least 2 sittings and that was a good thing. But we forget that we would have given the injection in the first go itself. That is one thing. And in any process, there is an induction thing. If it is taught in the preliminary stage, if the patient or something is known forever, if you start with the injection, the patient throughout the life knows that there is certain thing like injection, it has to be taken and as and when advised. That's
okay. Okay. Coming to Rajiv's talk, Atul, any difference?
No, sir. Same thing.
Anybody? Any difference? Only thing I found was your talk was slightly more weighted towards steroids.
Sir,
Both are there.
Yeah.
Definitely first slide is anti-VEGF, but there are some indications where you tend to think towards steroid. Again,
so what is your threshold of switch? 3 injections, 6 injections, Bristler says 6, somebody says...
No. Even after 1 I have shifted. It's not
After
like
1.
if there is worsening of diabetic macular edema, I will first...
Andy, your threshold of switching?
probably 6.
6. So here, most of us... Sir,
with the biomarkers now available, I think sometimes we even go in phakic patients with the large neurosensory detachments, you can directly go with the steroids because anti-VEGFs sometimes they don't, even the first 3 or 4 injections don't work in those cases. And the visual recovery is better with the one single steroid
So can I,
injection.
as you said, I also felt that there are some indications which you mentioned, such as the presence, presence of exudates. You said you would tilt towards steroid, but I haven't found that difference, and I haven't found much evidence in literature that exudates respond better to steroid. Second, also in post-vitrectomy eyes, you mentioned that steroid lasts longer, but there are studies which have shown that aflibercept lasts as long as steroid. So I would still prefer. Third is, if you had mentioned that if follow-up is not possible, then you would prefer steroids. But there again, the raised IOP is a problem. So again, that requires follow-ups. In fact, when a patient is not able to follow up, I would be wary of giving steroid. And I haven't found any difference in the duration of efficacy between steroid and a long-acting drug like aflibercept. So these were the points.